Hello, hello, my friends. Jill Osborne from the Interstitial Cystitis Network. It is Sunday, June 22nd of 2025, and it is time for another live IC support group meeting. My purpose in doing these meetings is to educate and to inform it. It is open to patients, it is open to family members, it is open to friends, anybody who has questions about patients who are struggling with recurring pelvic pain. Because it's real difficult. When you've got a pelvic pain disorder, nobody can see it. They can't see your suffering. They cannot see the fact that you might be running to the restroom. It is truly one of those conditions that are the most difficult to explain to doctors and the most difficult to explain to patients, because you know what? You look fine, and yet on the inside you feel terrible. I know this because this was my life for many, many years. And so our goal here is to educate, to inform, to give you better ideas on how to work with your doctors, some new potential causes for these symptoms that you might not be aware of, et cetera, et cetera. So anyway, it's been a week. I'm not 100% today, but I'm here. I'm really, really here. Here, hold on a sec. We're already getting reactions. Anne says, how can I stop bladder leakage? So the way I do these meetings, guys, is I usually do an intro for about 30 minutes, maybe less, maybe more. We'll see. And then I take your questions and we'll go as long as you want to go. I'm going to admit that I hurt my back quite badly. And we're going to see if my back can tolerate me sitting here. Mary says, our newest magazine is fabulous. Yes, thank you so much. Oh, so what she's referring to, the IC Network has a patient magazine called the IC Optimist. Here it is right here. And what we did in our latest magazine is we massively updated our flare management guide and expanded it. So not only do we have the basics on bladder wall flares, what the triggers are, what your rescue plan is, and let me give you an example here. Let's see here. So here's the bladder wall flare section. So we have risk factors, triggers, our rescue plan, what to do in that first. So as an example, first hour. Well, you know what, guys, let's just go over this real quick. I got other things I want to talk, but I really want you to understand the work that I put into this. So the patients who are going to be the most at risk for bladder wall flares are patients with Hunner's lesions or bladder wall phenotypes. Okay, that's easy. The basic triggers are going to be diet, vitamins and supplements. Hello, Debbie on YouTube. Hormones, chemical exposures. And then we have our rescue plan. And in the first hour, we're going to dilute your urine to reduce acid levels. We're going to alkalinize your urine. We're going to perhaps do some chamomile herbal tea, some peppermint herbal tea, which is very soothing to the bladder wall. It is a smooth muscle antispasmodic. Maybe use some heat, cold, et cetera, et cetera. And then I have all the things for second hour and then over the long term, when to call your doctor and all that sort of stuff. Oh, I'm so glad that you like it, Mary, because let me tell you, girl, I was working hard. So we have our pelvic floor flare. How are we going to work with muscles? So what do you do after you have your sex-induced flare? What do you do when you have a flare because you've been driving for a long period of time, including stretches, the stretches that you can do to relax these muscles. Lots of stretches. Then we have our pelvic neuralgia flare. So what do we do when your muscles are so tight they're now squeezing nerves? Because that's big time pain, my friends. That is big time pain, because not only do we have to calm muscles, we got to relax these nerves that are now screaming. What to do with stress flares. This is very new. We've never talked about stress flares before. I don't know. Here, hold on. Let's try that a little bit better. This was a demo that they did in a different paper for me, and I don't like it at all. For our members, it's in the regular, really high quality paper. We have our menstrual flare. What do we do with menstrual flares? Etc. Etc. The urethral flare. What do you do when your urethra is starting to scream in pain? The vulvodynia flare. The rectal flare. Oh my God, come on. Now listen. Am I crazy? But, I had IBS in my 20s, and I was too embarrassed to talk about it, period. I was too embarrassed to talk to my doctor about it. Until it got real bad and I really didn't have a choice. But even when I got older, when I got much, much older, I had the most adorable primary care provider. And I just couldn't talk to him about my rectal pain. I was just like, no, you're too young and you're too cute. I can't do this. And so I would just like, I said, one day, we're going to talk about my rectal issues, but not right now. And he finally goes, Jill, I have Crohn's disease. Believe me, if there's anybody you can talk to about rectal issues, it's me. And I saw him in a whole new light, this gorgeous, handsome, hunky doctor, Crohn's disease. Anyway, so tips on how to handle rectal flares. Anyway, there's a sex flare, allergy flare section too. So if anybody wants our updated flare management guide, it is available in the IC Network shop. It is, if you're a member, it's already on your member page. But, okay, so today we're going to talk about three things. We're going to talk about summer vacations. We're going to talk about embedded infections. We're going to talk about one very interesting new research study. But I'm going to start with embedded infections for a moment because I have my first criticism of this from a patient yesterday. And I want to address what she said. Because let's see, how do I want to say this? Hi, Kayleen. Julie, you clearly have something that's very, very important for you to say. And we can talk about that, honey. Hi, March. Okay. If you've been online as long as I have, remember, I built one of the very first health websites ever. I am the fairy grandmother of the IC movement. I mean, that's kind of how I see myself. I built the IC network. I started building it in 1994. I started the very first online support groups ever for urology on America Online and on CompuServe. I've been around, my friends. I have been around. And from day one, we had a group of people who kept saying, you all have infection. You all need antibiotics. Kayleen said, I started at the year I was born. Girl, exactly. This was back when we had something called internet news groups. Internet news groups. Internet news groups were kind of like the wrestling area of the internet. That's where the most hostility happened before social media, was in internet news groups. And the internet news group that were set up for IC and for prostatitis were just landmines of fighting. And there was this small but very, very vocal group of patients who kept saying, you all have infection, you all have embedded infection. This is 30 freaking years ago. And what was even more reckless, and in fact, it was one of my co-leaders who kind of went off the deep end a little bit and started saying, you all need to take antibiotics. Antibiotics are perfectly safe. Hi, Susan. And I had to challenge her on that because I almost died from tetracycline. I mean, I went into anaphylactic shock with tetracycline when I was a kid. Antibiotics are not necessarily safe. And we got in a little bit of a tussle, but that's fine. I'm perfectly prepared for anybody out there. Listen, I got the goods to back up what I'm saying. If you don't think I'm saying something that's correct, reach out to me. Let's talk about it. I will show you research. I will show you perspectives on where I'm getting that information. And please understand that I am a pharmacologist first. Okay? Drug development. That was my original career path. Turned out I just loved animals and I didn't want to experiment on animals, which is why I went into psychology. Okay. So the tactics that were used by these patients 30 years ago were very aggressive, very in your face, exactly what we see today on social media. I mean, internet news groups were the training ground for Twitter wars today and social media today. Back then, the theory was that, and this was promoted by a lovely old gentleman, his name is Dr. Paul Fugazzato. He ran a lab in South Dakota where he believed that he could prove that IC patients had something called a fastidious infection, a small but deeply embedded infection. And he said, if we do a broth culture, a long-term culture, a 5-day culture of your urine, we can find that infection. So back then, we all did that. I did that. Every woman in my family did that. Every IC patient I know did that. That's what we had back then because we were all grasping at straws. Well, so my result came back that I was positive for Enterococcus and Micrococcus. My mother's came back, hers was positive for Enterococcus and Micrococcus. Pretty much all of my friends who had it done were positive for one or the other. Now I'm here going to all these urology conferences. And I'm talking to all the top researchers because, you know, I'm a bold bitch, for lack of a better term. My motto is be bold and mighty forces will come to thy aid. So I will walk right up to a top doctor and ask them their opinion on something. So that's what I did. And everybody, and by this time too, guys, we did over 100 live events on our website. I even had the director of the National Institutes of Health in my back then would have been a podcast. I asked every single researcher, what do you think about the embedded infection theory? Hundreds of people. Not a single person believed it. Okay. Now I met Dr. Paul Fugazzato. He was adorable. I had lunch with him at a conference. Good man. He was sincerely trying to improve our lives. But there was a flaw in his methodology. He did something called heat autoclaving. So he sent out glass bottles about this big. We all got them. And we collected urine, we put it into the glass bottle, and we sent it back off to him next day. So we'd get it 2 or 3 days later. Heat autoclaving does not kill many bacteria. It does some, but not others. So the general consensus, as I was talking with these other scientists, is that his samples were contaminated because of the glass bottles. And that makes total sense. I mean, I've worked in labs, total sense. So lovely man, flawed technique. He has since passed away, and I applaud him for sincerely wanting to help. Well, so things kind of quieted down, you know, but then social media happened. And when social media happened, our embedded infection, recurring fastidious infection people found a new platform. Now, these are men and women who truly believe that they have infection. And some of them really do better on antibiotics. I was working with a patient on Friday. Absolutely. Definitely something very, very funky going on because he had been on antibiotics for an extended period of time, aggressive antibiotics. Every time he stopped, his symptoms came back. And our challenge here is then to figure out, okay, how are the antibiotics helping? Well, antibiotics, number one, have a nice anti-inflammatory effect. So one of the reasons why you might feel better on an antibiotic is because it's reducing inflammation. Concept number two for him was that I think, and he's going to do the next generation DNA urine testing to prove it, I think he's got a really, really aggressive drug-resistant infection that keeps coming back. Okay. But we have to follow the science. We have to follow the science. It was the University of Maryland who first did preliminary bacterial studies on IC, looking for the elusive smoking gun. And the name of the researcher was Susan. I don't remember her last name. It will come to me. Didn't find anything. Didn't find anything. And a number of other doctors, especially now that we started doing next generation DNA urine testing, looked to characterize the urinary biome because urine is not sterile. There's good bacteria that live in urine, that live in the ureters, that live up by the kidneys. And what they consistent, and again, people are looking for the smoking gun. Everybody wants a smoking gun. What is it? And again, what those studies showed is that we have a perfectly normal biome, not dominated by any single pathogen when you look at IC urine as a whole. But it's less diverse than normal, and there's more lactobacillus than normal. Okay. So if we have a normal biome, does taking antibiotics, especially antibiotics over time, make sense? Now, of course, if you have an infection confirmed by testing, whether urine cultures or next generation DNA urine tests, hell yeah, you're going to treat it. But the person that reached out to me said, I know thousands of patients who have gotten better. And her opinion was that pretty much most IC patients have embedded infection because I know thousands of patients. Yeah, but there are millions of patients. So let's just benefit of the doubt here. Let's just say that there are 5 million IC patients in the United States. And let's just say that there are 100,000 patients who have a funky infection. So what is that percentage? Like 0.1% or 1%? Don't ask me to do math right now. It's tiny. It is a tiny, tiny percentage. Now, that's not taken away from the fact that they're suffering from an infection. I get it. They are completely suffering from infection. But we cannot, based upon that, say that every IC patient should be on long-term antibiotics. There's simply no data that shows that it works. And there is data that shows that if you take antibiotics for a long period of time, you run the risk of developing superinfections. So our challenge here, and this is the challenge with with the online community and the Facebook groups and all of the groups right now is that they're operating from the assumption that we're all the same, and we're not. We have very clear, distinct groups in the IC patient population. 85% of IC patients have tight pelvic floor muscles. That's millions of patients who have tight pelvic floor muscles. That's very different than maybe, and again, there's no data to support 100,000 patients with recurring UTI or with a fastidious or embedded infection. I'm just throwing that out there as an example. So our national guidelines strongly suggest pelvic floor physical therapy. The point that I'm trying to make here is that anybody who suggests to you that everyone has this or everyone has that, they're not living in reality. If you come to a support group and you meet patients physically, not online, but physically, you see the diversity very, very quickly once we start sharing our stories. Because for some people, IC begins in childhood, while for others, it begins after menopause. Same diagnosis, but are we the same? Hell no, we're not the same. For some people, IC begins because they've gone through chemotherapy and the chemicals of chemo have badly damaged their bladder. That's not infection. That's a chemical injury to the bladder wall. While for many others, IC begins after they fall and break their tailbone because they have a muscle and nerve injury. Now, this one treatment fits all approach, these wide scale statements, you all have embedded infection, you all need to be on antibiotics, is ridiculous. But believe me, I fully intend to support any patient who has infection. Because some of you do, and some of you have gotten better on antibiotics, and I'm really glad you have. But for me, hey, listen, I did the fuzzy protocol. That's what we called it. Dr. Fugazato, we called him Dr. Fuzzy. What was his protocol? Long-term antibiotics. I did Augmentin for like 6 months. I ended up having, I think I was the very first drug-resistant candida infection they had ever seen at my local Kaiser Permanente. I had the worst candida infection throughout my body from that long-term antibiotic. And I had doctors yelling at me. I had one lady doctor, like, it's impossible. There's no way you took diflucan for 2 days. And I'm like, I'm not here because I want to be here. I am here because I am in agony, because I'm going to tell you right now, fungal infections hurt worse than anything else. Having an active fungal infection in your bladder is brutal. And I just said, prove it, do a swab. And she was very aggressive. She jammed her thing up my vagina to get that sample. And she was really mean. And she came back 2 minutes later and said, I'm so sorry. You absolutely have infection, a fungal infection. Chloe says, how did I get rid of the candida? I had to stop feeding it. There is a great book called The Candida Connection in Women, the Yeast Connection in Women. And, so you have to understand that good bacteria in your body normally control fungus. However, when you've killed the good bacteria with antibiotics, now the fungus can grow and thrive. And that's one reason why many people suffer from candida infections after they take antibiotics. And I'm going to tell you, with mine, I had no discharge. There was, normally they say you look for a white cottage cheese-like discharge. I had no discharge at all. All I had was searing, agonizing pain. And so we did massive levels of diflucan. I mean, I was to 450 milligrams a day for 7 days. We were at the high liver toxicity level. I was doing a lot of liver tests to make sure it wasn't damaging my liver. I had to do that 3 times in 2 years. We painted my bits with gentian violet several times to kill candida that might have been living on my skin. But in the end, I had to modify my diet massively. As Allie just said, no sugar, starch. And you're right, I did garlic hunt. I did all that. I had a very, very aggressive Candida glabrata infection. Interestingly, to bring this up, I spent the morning going through the latest research that was presented at the American Urology Association. And what did I find? What did I find? A new fungal microbiota of urine. Yes. And so now we have another study that has found, now here, hold on a sec. Let me just open this up here. So in this case, they were looking at the urine of patients with overactive bladder, frequency, urgency, incontinence. So they had 102 patients with overactive bladder, 54 were controls. Fungi was detected in all but 3 urine samples. Okay, so 99 patients had fungus in their urine. The fungal diversity was different between the patients who were symptomatic and patients with controls. The overactive bladder patients were dominant in a fungus called Ascomycota, whereas the controls were dominated in Basidiomycota. And they also found that 2 different species of fungus were much more abundant in patients with overactive bladder, and that 2 different ones were more dominant in patients with normal controls. And there was a difference in patients who were incontinent versus patients who were not incontinent. So patients who were overactive bladder wet had much more fungus in their urine than patients who were not incontinent. And so they conclude the urinary fungal microbiome differed significantly between individuals with overactive bladder and those without urologic diseases. We detected differences based on phenotypes. The result supports a further study regarding the relationship of fungi, yada, 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 and to try to identify the fungal biome. And so let's get back to that embedded bacterial infection theory. So again, remember, I've been dealing with these guys for 30 years. What a lot of the new research is now finding is rather than the smoking gun bacteria, what we're finding is the smoking gun virus in the urine of patients with Hunner's lesions and a smoking gun fungal infection, which typical urine tests don't look for in some bladder patients. And this is research from our own US National Institutes of Health. They're the ones who found the fungus. They're the ones who went, oh, look at that. The more fungus in urine, the greater the bladder pain. So that raises yet another really important distinction that you've got to make when you're reading some of this embedded infection stuff. And that is, they're going bacteria, 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 antibiotics, antibiotics, antibiotics. But we've got outstanding research, which is instead of finding bacteria, they're finding fungus or virus, for which antibiotic therapy will actually help the fungus grow. And of course, will do absolutely nothing for a virus. So anyway, this comes up couple times a year. I will tell you, like in the Reddit IC group, the other challenge that we have is that the embedded infection community has been incredibly aggressive. Not the person who wrote me. The person who wrote me was quite lovely. That was fine. But they have come into these meetings. They have kind of swarmed Twitter. And they were so aggressive with me early on that I had to reach out to Dr. James Malone Lee and say, would you please tell your people to back off? And he didn't know what they were doing. And when I showed him what they were doing, he was appalled. But he was like, no, those aren't my people. And I'm like, well, they're talking about you a lot. So if there's anything you can do to help so that we can reduce some of this hostility online, that would be great. So again, to summarize, we have multiple phenotypes. We got the Hunner's lesion phenotype. That's about 5% of patients. We got the bladder wall estrogen atrophy group. We got the bladder wall chemocystitis or chemical injury group, including ketamine cystitis. That's probably, I don't know, maybe 20 to 25% of the IC patient population. We have the tight pelvic floor dysfunction group. That's 85. Now remember, there can be overlap. We've got the pudendal neuralgia group. That's pretty small. On my guess, and again, this is my guess. I can't back this. I'm not going to be able to back this up with research. This is my guess. I think the pudendal neuralgia group is probably 10 to 15% of patients with pelvic floor dysfunction. And then we have our widespread pain group, and that's about 40%. But again, there's a lot of overlap. And the point here is you don't just pick one. We want to treat anything we can find. So if you got UTI, we want to treat the UTI. If you got a Hunner's lesion, we want to treat the Hunner's lesion. If you got tight pelvic floor muscles, we got to treat the tight pelvic floor muscles, because tight pelvic floor muscles can do a lot of damage to muscles and nerves and blood supply. If you've got widespread pain, we got to treat the widespread pain. We've got to calm the central nervous system down. Because for those of us who have widespread pain, that's usually a history of injury that's basically injured the central nervous system. And so we have to address the fact that our nervous system can intensify the pain, amplify the pain. So we've got to bring that down. Susan said, Dr. Evans told me one time that my urine was allergic to my bladder wall. What does that mean? I think that vice versa, that your bladder wall was actually allergic to something in your urine. That allergenic cystitis is actually proposed as a phenotype by Curtis Nickel, our top IC researcher up in Canada. And he said the way you can determine if somebody has allergenic cystitis is you just poke the bladder wall. So if they're doing a cystoscopy and they just push it right into the bladder wall, if they poke it and you get a little red spot, a little bit of what they call a mucosal wheal, that's a sign that we've got some mast cell activity, allergenic activity happening in the bladder wall. So if you flare during allergy season, then that kind of potentially puts you in that group. And then using an antihistamine during allergy season might be reasonable for you. Anne says, how do I stop bladder leakage? Well, bladder leakage is usually caused by very weak pelvic floor muscles. It can also be caused by damaged nerves, but most of the time it's caused by weak pelvic floor muscles. And that weakness often happens as estrogen levels drop. When your estrogen levels drop, your muscles get weaker. And physical therapy, Kegel exercises are the best choice of treatment. If the muscles are severely prolapsed and physical therapy is not effective, then they might give you a pessary, or they might even consider surgery to stop that. Susan says he put you on hydroxyzine. Good. Hydroxyzine is an antihistamine that's done that. Allie said, wow, I've heard so many things that are just craziness. The doctors don't actually know for sure, still after all these years. But see, Allie, this is the problem. It's not one thing for everybody. It's not. That we have worldwide consensus among the top IC researchers now that there are distinct patient groups. This is why we don't use the name interstitial cystitis in the great majority of the world now, because it implies that we all have a problem with the interstitial layer of the bladder wall, and we've known that's not true for 80 years. IC is now a pelvic pain syndrome for which there are many potential causes. Our job now is to try to identify what your underlying cause is, and we do that with phenotyping. If you get phenotyped properly, that will then help us try to find the underlying cause for your symptoms. So, as an example, if your symptoms started in your 40s or 50s and you had no history of any bladder issues before, the very first thing we're going to look at if you're a woman is estrogen atrophy. Because as your estrogen levels drop, your bladder wall gets thinner and more vulnerable. Well, if you were working with me, one of the questions that I ask is, well, I ask how old you are, how old were you when your symptoms first began? And the most important question is there any event that you associate with the onset of your symptom? A fall, a car accident. We had one patient last year, fascinating story. No history of any IC symptoms. She went and spent a month or two in Central America with her family. I think they were doing some research. And that involved her hanging out in brown, muddy rivers. So when she came back, bladder symptoms, really persistent bladder symptoms she'd never had before. She ended up being diagnosed with interstitial cystitis. However, what the treatments they were giving her were doing nothing. Her bacteria tests were coming back normal. They weren't finding typical infections. But in her case, what she had was a parasite in her urinary tract that she got from a river. And she's not the first. I've worked with several patients who have gotten parasites in their urinary tract. Allie says, mine began in my late 20s when I had severe endometriosis. Exactly. And that endometriosis group, man, that endometriosis group is way bigger than the UTI group. Because there are millions of patients who have endo. And, and we were just talking about that last weekend at the International Pelvic Pain Society conference. It was a 2-day conference. And I haven't written up my notes yet on that. I will eventually. So endometriosis can do a bunch of different things to the urinary tract. The first thing it can do is it can attach to the outside of the bladder. It can basically burrow through the bladder wall, and it can end up living inside the bladder wall. And once it penetrates the bladder wall, man, it is a war. It is a war. That bladder is going to be screaming in pain because of that endo. But the other thing that endometriosis does is it triggers such intense neuroinflammation throughout the pelvis. And so patients with endometriosis are now being treated in the widespread pain group because we have to do some of those systemic nerve calming therapies to try to help bring the volume down on all that neuroinflammation that the endometriosis has caused. Allie said, I was diagnosed by bladder distension during a surgery to remove a cystic ovary. And then that's a whole nother story because a bunch of us have had polycystic ovarian syndrome, myself included. There is a researcher down in Texas, and her name is just going right over my head, where I want to get where she's pursuing another potential trigger for some of these symptoms. And of course, the whole thing with the infection is we always have to ask, especially for patients who get multiple infections, is there a problem with their immune system? Because sometimes patients have immune system disorders. Debbie says, how do you get phenotypes? We have a video on it. We got multiple videos on it. You can call me. The top doctors are doing it now. There's a lot of differing opinions out there. Some doctors use smaller subtypes. Some use more, like Curtis Nickel uses 9. I use the 5 phenotyping system from Chris Payne. AUA uses 3, but they basically combine a couple of them into one. Our goal here is the more the more specificity we can find, the easier it is to identify effective treatment. So, a lot of patients say, well, I'd like a cure. And it's like, well, you don't cure an injury, you heal an injury. You don't cure, I mean, we're just trying to really move away from the perception that this is an incurable bladder disease process. Our national guidelines say this. We just don't find bladder disease in the great majority of patients. We don't. The only patients with bladder disease are patients with Hunner's lesions who have viral infections or patients with an infectious disease process. Now, then the other operative question is, what about autoimmune disease? And there were a couple more research studies that were released at AUA that talked about that. Some pro, some con. There are doctors who say IC is an autoimmune disease. And again, when we ponder phenotyping, the pelvic floor patient does not have autoimmune disease unless they also have Sjogren's or lupus or maybe arthritis, rheumatoid arthritis. So I think that autoimmune group, based upon previous studies, is probably 3%. I think maybe 3% of IC patients, 3 to 5% might have autoimmune origins for some of their symptoms. We just have a lot of debate going on. There's just a tremendous, understand that the IC world has been put on its head. And it's shaken out now. It's just shaken out. Everybody agrees Hunner's lesions are their own unique group. Everybody agrees pelvic floor is its own unique group. Everybody agrees widespread pain is its own unique group. But there are lots of other groups that have to be considered too. Okay, so anyway, that's my little mini rant about that. I do briefly want to celebrate. Hello, it's summertime. Yes, it's summer. It's fun. I live in California, Northern California, and I got to tell you, it's the coldest winter and spring of my life. I am not a happy girl if it is not warm outside. I need sunshine. If it's 90 degrees, I am happy. If it is 50 degrees, I am not happy. If it's foggy, yuck, no, give me sunshine every day. That's what I live for. So we need to talk just a little bit about vacations because I don't want you at home alone. I don't want you to stay behind when your family and friends go. There are ways that we can make vacations more bladder friendly. So is this the time to get on a plane and fly to the Bahamas? No. Is this the time to get in your car and drive an hour to the beach? Yes. Yes. So we're not talking big vacations. We're talking daycations. Nearby that you can easily get to. And more importantly, you can easily get home. So if you start to feel bad, you can just get yourself home. How do I want to say this? Prepare your body well. Let's say you've got a family reunion. You got a family reunion on August 1st. Might be a 2 or 3 hour drive, maybe a little bit longer. You really, really want to go. You're really worried about the drive. Follow the IC diet, do your pelvic floor work, and just chill your body out for a bit. Just chill it out. Now, I will tell you, for me, I take a lot of emotions out of it. I just don't allow myself to go upset. I just wait and see how I'm feeling on that day. 9 times out of 10, I'm feeling okay and I'm going to go. But if I wake up in that morning and I'm having a wicked flare, which granted I haven't had in 20 years, but I'm talking back when I was really bad. I do give myself permission to stay home or I did give myself permission to stay home if I needed to. You got to bring your toolkit. This means bring heating pads, your body heat heating pads, so you can wear them in the car. Have a little bit of heat on your pelvic floor. Really helps calm the pelvic floor tension from driving. They're in the IC Network shop. They're really, really cheap, very cheap. If you need a cold pack, you can bring cold packs. Do a little cooler with some ice in your cold pack. Bring your Tylenol or whatever you're using for pain control. You can bring your Pea Leaf. You can bring your Peora, things like that. If you need your bladder pain relief tablets, your Pyridium, bring that. This is the time for super comfortable clothes. Please do not wear your shortest outfit with very high heel. That's going to tweak your pelvic floor. Guys, yoga pants, yoga shorts, just be comfortable. Flat shoes, we don't want to tweak the pelvic floor at all, and high heels are going to do that. You want to bring a chair cushion for the car ride. Whoops. Like this that I'm sitting on. Oops, hold on. Now I got to fix myself. Okay. I have to sit on it. When it's summertime, you have to put a towel on top of of that specific chair cushion. Otherwise, it gets sweaty. And I gotta, because I hurt my back, I got an extra towel here on my back. Bring your favorite IC friendly snacks for the car ride. Bring a great book or have the kids watch videos. And if you get stuck, make sure you bring just a couple of extra days for your meds, extra days of meds if you need them. I think it's really important if you're going on a car drive with somebody else and you're not driving, you need to talk to them in advance about your need to stop and use the restroom. Asking you to hold it is cruel and unusual punishment. Bladder pain hurts badly. And you got a full tender bladder in a car bouncing down the freeway. We're talking agony. We've all been there. So you need to have a very clear discussion with who's ever driving that when I say we need to stop, we need to stop. If that means we're going to stop every 45 minutes, we're going to stop every 45 minutes. At the same time, you're going to bring your travel johns. Here it is. Hey, listen, man, we are prepared. Travel johns. Look at this. This is a little plastic thing you can put in your glove box. That's how big it is. If you get in a pinch and there is no bathroom nearby, you can pull over, open the back seat door, open the front seat door. You've got block there, block there. Hopefully they're just cows in the field. You can pee into this in the car. I always have these in my car. And you know what? I've never had to use them. But knowing that I have them gives me confidence. If I ever got in a pinch and I needed to pee right here, I can pee. Some people have pop-up tents in their car. So a little pop-up tent is like the size of a little mini dressing room. And you can just open up, you just literally, we sold them for years. Just pop it open. The whole thing opens. It's like 6 feet tall. You can just set it next to your car, step in there, pee in this. When you're done, just step out. You just throw the travel john in the nearest trash can. It does not stay wet. There's a powder in here. It immediately solidifies. It does not smell. Put it in a plastic bag and throw it in the next trash can. Break down your tent. You're good to go. You can pee on the side of the road in 3 minutes. Super easy. And if that person says, I don't want to stop, then I would not be going with that person. They need to respect our needs. They need to respect your needs. If they are not respectful of your needs, then that's probably not somebody that I want to be driving with. And if that means you have to drive yourself, knowing you have control, you can try that. Just got to be real here. Driving across the country, probably not a good idea if you're having active IC, active pelvic floor. Small trips, small day trips. All right. All right, we got a lot of chats here. So we are simulcasting right now. So when I'm looking here, I'm looking at Facebook. When I'm looking over here, we're looking at YouTube. Shemper says, my functional doctor recommended I use 3 to 4 tablespoons of apple cider vinegar and water throughout the day. He recommended that because my urine came back that the pH was abnormally alkaline. Hi, Donna. Hey, girl. No, long time no see. Shemper, it's never my position to interfere with what a doctor is telling you to do. A number of patients have shared that they have tried apple cider vinegar. For some patients, it's been helpful. For others, it's been painful. You just won't know until you try it. It's not something that I'm a particular fan of, but you know, urine by its very nature is usually slightly acidic. It's like in the pH 5, and then as the day goes on, it gets a little bit more alkaline, if I remember my facts correctly. If your urine is coming out right out the charts at like a pH 8, sounds like you could be drinking a lot of alkaline water. Not a fan of alkaline water at all. Oh, and God, what was it? There was somebody else. How was it? Somebody called me this week and their doctor had them doing like a half a teaspoon of baking soda in water like 3 times a day. Just way, way, way too much. Because baking soda is sodium bicarbonate, and that's going to raise your blood pressure. And she happened to be an elderly woman with blood pressure issues. So the best thing we can do for our urine pH is to drink water to keep it as dilute as possible, and then make sure you're not doing a lot of sodium bicarbonate or doing a lot of acid. Try to be pH neutral. That's the only thing I can say. There was something else. Something is between. God, was I talking to somebody like a month ago about this? I just don't remember the details of it. April says, and take vitamin D3? I take vitamin D3 every day. Good things about IC? No, not really. But our vitamin D levels tend to decline as we get older. And so doing a little bit of vitamin D every day makes sense. Here, hold on. I need to scroll back to the beginning here. Judy says, here, hold on. Facebook always makes it hard for me because it just jumps around all the time. See, it just did it again. Come on, let me read the messages in the back. Stop that. Hi, Judy. Hope to give you a call soon. Questions? Yeah, guys, anybody can call me. It's fine. Oh, I'm sorry, guys. Facebook makes it so hard because it just jumps all over the place. Even if I'm holding it with my finger, okay, it still does it, and it makes it almost impossible. Listen, if you asked a question on Facebook and I didn't answer it, please ask it again. Don't take it personally if I missed it. Facebook makes it very difficult for me to read messages, especially if I have to scroll back, because you know me, I tend to talk a lot. Lisa, thank you so much for the 50 stars. Really appreciate it. Very, very much so. Anne says, what's the difference between a UTI and a bladder flare? Well, a UTI is an infection. A bladder flare can be from drinking coffee. So if you've irritated your bladder, so let's say you're menopausal and you've got a dry bladder, you're on Lupron for endo, or you're on birth control, and your bladder just doesn't have that normal level of mucus in it because you're not giving it the estrogen it needs to make the mucus. your bladder is now compromised. The bladder wall, the urothelium, the gag layer is thinner. The bladder is more vulnerable. The bladder can't defend itself without that nice thick coating of mucus. And so that's where diet really matters, because if you put a strong acid in a bladder that doesn't have any protection, you're going to have a bad flare from that acid. This is why so many patients flare from soda or from coffee or from green tea or from matcha, things like that. So that type of flare, that's not an infectious process. That's just superficial irritation of the bladder wall with something irritating. That's very different than having bacteria that are chewing into the bladder wall and converting cells in the bladder wall into bacteria factories. Debbie, going for a cystoscopy tomorrow with hydro. Let's see how that goes. Wish me luck. Debbie, I wish you really good luck. I hope that it goes well. Now listen, couple of things with your hydrodistension. Number one, ask them to take pictures, because you need pictures in your medical record. And for you to have a picture that you can show to other doctors or you can show to the emergency room. Let's say you've got Hunner's lesions and you've got a really very, very injured, damaged bladder. Having pictures of that you can show to other doctors is really, really important. So like the most important thing for you to get out of that hydrodistension is either a video or pictures. So please ask them to do that. Number two, you want to ask the doctor if what they're going to do if they find Hunner's lesions. If they find active lesions, how are they going to treat that lesion? Because the worst thing they can do is say, yeah, look at that. You've got 3 Hunner's lesions, and leave them there. Because the best way to treat a lesion at this point in time to stop your pain is by cauterizing it closed. If they cauterize it and seal it, guess what? The lesion doesn't hurt when urine goes into it. So the great tragedy are the number of patients out there who have had hydrodistension. They've told that they've had lesions, but they were never treated. And that's heartbreaking. Like the number one cause of severe, intense pain over time in some patients is clearly Hunner's lesions that were never treated. And then number three, listen, with the hydrodistension today, they're supposed to be doing less stressful and traumatic hydrodistension. So what that means is that instead of a high pressure, long duration hydrodistension, where they put a lot of water in your bladder and really, really stretch it out, today they're supposed to use less water for less time to minimize trauma to the bladder wall. And so hopefully they're going to do that. Post hydrodistension, I mean, I had one like 5 or 6 years, no, like 7 years ago. Some patients go out to dinner that night. They're like, fine. Other patients are in bed for a week. Normally, they would give you an antibiotic during or after that, just to reduce the risk of a post-operative bacterial infection. Normally, we would expect that your urethra would be pretty tender the first day or two, but after that, that should get much better. And you will have good information to base your future decisions on. You've taken it away from a guess, and you're now making treatment decisions based upon a fact. And if you come out of that with a perfectly normal bladder like I did, then that tells you that your symptoms are being driven by something beyond your bladder, that your symptoms are being driven by nerves and muscles. Or something else like a fibroid tumor pushing on your bladder, endometriosis attached to your bladder, etc. So if you get really good news and your bladder appears normal, great, we're going to celebrate that. You've got a healthy bladder, fantastic. So we're not going to waste time doing old bladder treatments. Now we have to look beyond the bladder at the other things that could be causing some of these symptoms, whether it be tight pelvic floor. So I really hope that you get some good answers from your hydrodistension. Good luck, my friend. Allie said she had to go into cryogenic surgery to remove all the endometriosis. It was extensive. Girl, yikes. She did an elimination diet for a year. I was strict. My bladder began to heal. At the end of the year, I added one item at a time as a test. I had very few flares. Good job, girl. Good. Excellent. Usually my own fault for eating or drinking a no-no. I have to tell you, guys, listen, nobody's perfect. Nobody's perfect here. I did the stupidest thing last week. I had a kind of a weird week. So here I am working out at the gym, feeling great, finally able to do the things I couldn't do because of my surgery, my mastectomy. And I was listening to a blog that talked about what is the healthiest diet. And this blog said, you need to eat 30 different types of vegetables a week. And I'm like, well, I don't do that. I eat broccoli and zucchini and corn and mushrooms and potatoes. I've got my little handful. And I actually go to the grocery store and I'm counting up the vegetables going, I cannot possibly eat 30 different types of vegetables in a week. And so I thought, you know what? I'll just double up. And so Thursday night, yeah, I ate 2 cups of peas. 26 grams, no, 32 grams of fiber. Do you know what that does? Let's just say, yeah, I didn't do well the next day. It's kind of like during winter, I had split pea soup and I had a big bowl of split pea soup and then I ate garbanzo bean salad. I have a very intimate relationship with my bathroom. Kaylee says it's 92 in Illinois. Awesome. Love it, love it, love it. Tina says she's taking pre-leaf. Okay. So Tina, are you the one who was saying your doctor told you to do the vinegar? So the pre-leaf is going to alkalinize your urine. You're really only meant to take pre-leaf before a meal. You don't just take pre-leaf like candy all day, or take it any day just because. Pre-leaf does not treat your bladder. What pre-leaf does is it alkalinizes your urine. But you just don't want to keep alkalinizing your urine over time. You want to save it for when you're going to eat something that's irritating. Because all that calcium's got to go somewhere. And the last thing you want is for those calcium to go into kidney stones. And if you're eating a ton of calcium, you just got to understand your body's got to process that calcium. Lisa says, I've been in the hospital for 3 weeks and I had a septic UTI along with being told end-stage bladder and you need neph tubes to pee. This is sort of a wake-up call, but I've yet to figure out when I wake up from this bad dream. Oh, Lisa, honey, I'm so sorry. What was a septic UTI? Girl or woman? Man, that is a beast. What was the bacteria? Heartbreaking. Are you home? So are you home now or are you still in the hospital? Hello, Sue. Sue says, hope you're feeling good. Feels like 100 degrees, close to it. Thank you for the Xylomelt tip. Oh, good. You got them? Sue was having really bad dry mouth. And I mentioned that one of the things that I really liked when I was really struggling from dry mouth, it's a Xylomelt candy that it's not overly sweet at all, but you kind of tuck it on the inside of your lip and it just slowly dissolves and it helps your mouth produce mucus. I'm so glad that it's working for you, honey. Allie says, my honey knows the car stops every half tank at a minimum. There you go. Tina said, I'm going on a 12-hour road trip next week. Luckily, there will also be kids that need to stop frequently. Yeah, excellent. Alex says, I would not recommend ACV. Not sure what that's referring to. Kayleen said, do travel johns make a trickling sound during the flow? I think my medical driver used one when I was in the van. I mean, if you're peeing like a horse into this, yeah, it's gonna make it sound. Allie says she takes vitamin D3 daily, but has seen no change. Yeah, but see, I wouldn't expect D3 to make any change in your IC, honey. Not going to make any change in your IC at all. But it's important. Tina, thank you for the 20 stars. Katie says, I hope you're feeling better soon. You know, my motto is it's always something. It's just always something. You know, you just like my goal for this year is I don't want to be at a hospital or an ER for the entire year. Unfortunately, one of the things that I have is that I have a really weird vagal nerve response to my stomach getting upset. And that is my heart starts to race. So I did have that morning after the pee incident, I had about an hour of heart irregularity. So I was thinking about going to the ER, but my medicine stopped it. So that's the only time my heart gets weird, is if my stomach gets upset in a certain way. If I'm gassy, if I'm really, really gassy and belching, my heart does not like it. Otherwise, I'm perfectly fine. And I've had all the stress tests. My heart is strong as a horse or strong as an ox. But it just starts bouncing on my rib cage, and I do not like it when it happens. But I've had it for 30 years. My dad had it too. So Emily said, what about embedded infection? I'm skeptical when people tell me that worsening symptoms of my IC could be due to embedded infection not being detected in urine cultures. Emily, I completely agree. Be skeptical. Be absolutely skeptical. The embedded fastidious infection people have been very vocal for 30 years now. The harsh reality is that our guidelines do not recommend long-term antibiotic use. Pretty much every IC meeting I've attended in the last 20 years, we have talked about this, because the embedded infection community is so aggressive online and they give out a lot of bad information. Today, we're phenotyping, and now we recognize that the vast majority of patients do not have infection and do not have an active bladder disease at all. That for many of us, there are other things that are victimizing our bladder that are causing these symptoms. The other point that I raised earlier is that we're now finding fungal infections and viral infections in some IC patients, which also completely throws out the theory that we all have embedded infections. We don't. I think that there is an embedded infection phenotype. I think that it's very small, but it's there. And I don't want to discount those patients who have had active infections and have responded to antibiotics. But we certainly cannot make that general assumption that every single IC patient has embedded infection. It's simply not true. And we do, and our test results are showing us that. Sarah says, what is a flare? I've been in a flare since last July, where I've been screaming out in pain, shaking uncontrollably, sobbing every day for 11 months. I can only take a few short steps anymore, and I'm having excruciating spasms. If I can sit, I have to sit on 3 donuts. I've been on antibiotics for 18 months for UTIs. I have a suprapubic catheter, which causes damage to my bladder. Please help. All right. So Sarah, number one, we need to talk on the phone. And so if you could call me tomorrow, I would love to talk to you. So concept number one here is, and this is what I have to ask you, is I mean, clearly you've been on antibiotics for 18 months, but you're still shaking in pain. So clearly they're not working. And that there is something else that is driving your symptoms. So As an example, I was working with a patient last week who also was shaking in pain. And when I asked her, where is your pain? Is it inside of your body or on the outside of your body? And I went, okay, so with a vagina, yes. Agonizing pain, especially when she sat down. I think she was in her 80s. She did not know about estrogen atrophy, that as estrogen levels drop, the skin loses its moisture, its protection. So the skin gets drier and drier and drier. And you know how painful dry mouth is. Dry mouth can, you're just chugging water all day, just trying to ease the symptoms of dry mouth. Well, estrogen atrophy causes dry urethra, dry vagina, dry vulva, and dry bladder. These are mucous membrane organs, skin, that need mucus to protect it. Mucus production is estrogen dependent. So when you don't have the estrogen, you don't have as much mucus. And this is heartbreaking because this is incredibly treatable. It is treatable with topical estrogen. When you give that skin estrogen, it immediately starts to plump up and produce your own natural mucus. You can use vulva balm. The other thing to remember is that, so she had been given aloe cream. And aloe cream does not get the job done. It might be temporarily soothing, but the problem with aloe cream is that it's water soluble. Your natural mucus is not water soluble. Your natural mucus is hydrophobic. It pushes water away from the skin. It has an oil base. And so this is where we're going to do something like vulva balm on the skin on the outside to push the urine away from the skin. And vulva balm, as you can see, it's a very light jelly, very light, very, very light, not sticky at all, not messy. You can also go with coconut oil, but coconut oil is very messy and soaks through your underwear and your pants, and you end up with oil spots exactly where you don't want them. But vulva balm, this is perfect. This is mine. This is the one I use. That's why it's there. I'm kind of, because I'll be you guys, I'm going to be 65 in 3 weeks. How did that happen? It is so weird to be older. 65. Well, and so I've been in menopause since I was 52. And I can feel my skin getting drier and drier. And so I just recently started having more discomfort at the entrance to my vagina. And I knew exactly what it was. And I went and got my vulva balm, took it right away. So. Okay, so Sarah, if you, I'd be happy to talk to you even after this meeting if you want. Our phone number is right on the top of our webpage, or we can go into Zoom. If you want to go into Zoom, we can go into Zoom at the end of this meeting and we can talk a little bit, see if we can try to figure this out a little bit more. I kind of want to know, do you have pain when you sit down that gets better when you stand up? The fact that you're sitting on 3 donuts actually suggests to me that you probably have some pudendal neuralgia going on, that the act of sitting is pressing on a nerve. And so I want to know what's going on with your pelvic floor and your nerves. The odds are that's probably playing a much bigger role in this than you realize. Here, hold on a second. Okay. What's my favorite chair cushion for the car? Someone stole my Simply Purple cushion where I left it at a restaurant. So the cushions that we have, let me get the cushions that we have. Hold on. Okay. So I have a closet filled with cushions because I have had pain while sitting for the last 25 years because I have a pudendal neuralgia. So the IC Network, we actually manufactured cushions for about 20 years, but the factory closed during COVID. So we had a really good cushion that was really cheap. It was like $28. That was this shape, but it had fabric across the front. This is the one we have now. This is the Sun Cloud travel cushion. This is made by a different company. It's much more expensive, unfortunately, but it's a much higher quality than the ones that we made. Much better quality. The ones that we made, you'd be lucky to get 6 months out of it before they flatten, whereas these will last a couple of years. And you can see by the design that when you sit on this, there will be no pressure on your urethra, your rectum, your vulva, your prostate, etc. So if you've got crotch-centric pain, this is the cushion for you. It's a great cushion. The donut cushions put too much pressure on your pelvic floor. Not fans of the donut cushion. The other Sun Cloud cushion that we have is this cushion. So the advantage of this cushion is you can use it this way, or you can use it this way, depending upon where your pain is. If your pain is in the front, you flip it one way. If your pain is in the back, you flip it the other way. So we do have the U-shaped cushions. Yeah, we do have the U-shaped cushions in our shop. I know we have these. We don't have the travel. But what if you don't have pain in your crotch? What if you have pain in your glute like I do? My pain is like 2 inches to the left of my rectum on my left side. And so this is the cushion that I sit on. And this is called a waffle cushion. Not super thick, but when you sit on it, you end up with about 1 inch of air between your butt and the surface of the chair. And these will last as long as they don't get punctured. But if you have a cat that jumps up onto your chair, it's going to puncture it and it's dead in the water. This one in the IC Network shop. It comes in 2 sizes, comes in 17-inch and 19-inch for people who might be a wee bit on the wider side. All right. Yeah, I'm doing better than I thought I'd do, to be quite honest. I was just crying in pain yesterday. My back was killing me. Tylenol working today. Plus, I'm not pushing on it. I spent all day pushing and prodding the sore area on my back, which is probably a mistake. Kayleen said, ED treatment is helping me drink more water. Good. It's so cute how me and my peers have Stanley cups. The only thing is I'm peeing every hour and I'm not really supposed to leave the group or meal to use the bathroom. It makes the pee gag go crazy. So then I'm exhausted for the rest of the day. Is this expected while rehydrating after weeks of being dehydrated? I don't know, hun. Good question. I think that they need to be very, very respectful of the fact that you have a bladder issue and you need restroom access. And for them to not let you use the restroom is inappropriate. You have a firm diagnosis of interstitial cystitis. You need restroom access when you need restroom access. And that shouldn't be controlled, in my opinion. Susan said, I can't take estrogen because you've had cancer twice. Well, that's where the vulva balm shines, hun. And understand too, though, that topical estrogen is not associated with a cancer risk as compared to oral estrogen. So the topical estrogen is considered safe. I was treated for breast cancer last year, double mastectomy. My anniversary for my mastectomy is July 8th. That it's a day. I will be filming my 1-year follow-up blog or vlog. First question I asked my oncologist is, can I use topical estrogen? She said, yeah. She said, the research is really good. If I don't use it at my urethra eventually starts to sting. I don't use it internally very much, but I always use it once or twice at the entrance to my urethra to keep my urethra chill. Lisa is still in the hospital with multiple complications. The first culture was E. coli and Pseudomonas, and then the culture grew Rothia? What? Girl, I've never even heard of that. Hold on. Let's look that up. Rothia? No, look at that. There it is. Oh, okay. According to the American Society of Microbiology, it is an increasingly recognized as an emerging opportunistic pathogen associated with some device infections. So it's a micrococci, first isolated from the cheek and gingiva. So it's a mouth bacteria that looks like it can spread. Huh. Wow. What is this? Rothia is a gram-positive bacilli that cause a wide range of serious infections, especially in immunocompromised hosts. Risk factors include prolonged and profound neutropenia, malignancy, and indwelling vascular foreign body. Here we describe 67 adults at the Mayo Clinic with blood cultures positive for Rothia. 25 had multiple positive cultures. Common sources of bacteremia are presumed gut translocation, mucositis, and catheter-related infection. All were treated with vancomycin. Girl, I'm so sorry. That was from the National Library of Medicine. That was a study from 2014 from the Mayo Clinic in Rochester, Minnesota. What are they telling you? What are they telling you now? Are you do they feel like you're responding to treatment? I mean, they must have you on a different type of antibiotic now, like vancomycin, something like that. Ruth says, how do you use lactoferrin? Lactoferrin is an oral capsule. So you take it daily as a supplement. Kayleen says, I can go whenever as long as I'm not purging, which I don't. These groups are so important, so I'm not really wanting to leave. Then I have to have an hour. Then you have an hour drive home. I'm so proud of you, Kayleen, for doing that. Good job, my friend. Good job. Karen says, I have the powder lactoferrin, but how much do I take? Karen, the powder usually comes with a little tiny scoop. And I have a, here, hold on. I think I downloaded it last week. Let me see if I can find it. Or did I take a desktop? No, it's a download. If you email me, icnetwork@mac.com, I can send you a flyer they sent to me on how to use it when you get it in the powder form. It's a tiny amount. It's not like a teaspoon. I mean, it's like a quarter teaspoon or less, because it's basically the same amount that would be inside that little capsule. Come on. I know. I mean, we just had this last week, but maybe it was on this other computer. Email me, icnetwork@mac.com, and I'll find that for you. You guys on YouTube, you're being a little bit quiet. Okay, so what else happened? What else has happened this week aside from my fiber drama? So we had the International Pelvic Pain Society meeting last week, and I will say that we are making such incredible breakthroughs with understanding the chronic pain, what drives chronic pain, and how to treat chronic pain, including chronic pelvic pain. It's just becoming so incredibly important that we recognize the role of the central nervous system in perpetuating chronic pain, and understand that trauma, accidents, injuries, adverse childhood events, all of that can drive a lot of persistent pain. What I mean by that is it's not the cause of it, it is amplifying it. It's pain is, you have to understand, pain's either going to come from an organ or nerve, it's going to come from a muscle or your skin. That's it. So the underlying cause of pain is really simple. There's either a problem with an organ, there's a problem with the nerve, there's a problem with the muscle and or fascia and or a problem with the skin, whatever. It's fairly uncomplex. The challenge is when you've got a screaming bladder, you go to a urologist. It's like, there's clearly a bladder problem, right? So fix me, give me antibiotics. And lots of patients have been on antibiotics for many, many years, and they've never gotten better. Or if you've got vulvodynia, you're going to go to a gynecologist, and they're going to focus on your reproductive tract. If you've got testicular pain, you're going to focus on that area. The challenge with Western medicine is that doctors play in their sandbox. They don't look outside of their sandbox. And as Dr. Jerome Weiss says so beautifully in his book, Breaking Through Chronic Pelvic Pain, nothing operates in isolation in the pelvis. Everything influences everything. You can have a problem with your bladder that then the pain is so severe, your muscles get tight and your nerves get squeezed. You can have an old injury to your muscles, and that injury has scar tissue, and that scar tissue is now binding a nerve, and that's going to affect your bladder, etc. It's just nothing operates in isolation. We have to look at relationships. We have to look at how they influence each other. And for chronic pelvic pain, the role of the central nervous system is becoming more and more defined, because now that we can see that patients who do have widespread pain are stuck in fight or flight. The 24 hours a day, 7 days a week, their brain is behaving as if their life is at stake. That's a result of injury and trauma. And we know that if we can get that brain out of fight or flight, we know that the pain will calm down. The entire nervous system calms down. But nobody is saying this is mental disease, mental illness. Nobody is saying that. And nobody is saying that this is all in your head. What we are saying is that there is injury to the nerves. And we have to understand what that injury is, and we have to try to restore good nerve function. And central to that is making sure that you're not living in a state of anxiety, because when you're anxious, your brain's going to amplify everything. We've got to bring the anxiety down. Lisa says, not on vancomycin. You're cured of the infection, but now you have multiple complications. Like what, Lisa? Karen says, the mail, IC network at Mac. That's short for Macintosh computer. IC network at mac.com. Kayleen says, thank you. I have to fight so that I can stay longer in this program. I'm only covered for 11 days, and that's definitely not 6 weeks. Get what you can, girl. Get what you can out of it. Mary says they should have some specialty that addresses the whole pelvic area instead of those individual docs focusing. You're right. They should. And in fact, that's something that Dr. Robert Eckenberg and Ken Peters and a couple of other docs, they have been trying to do that. In the International Pelvic Pain Society, I think they have come up with kind of a new pelvic pain certification. They were talking about it last week. I didn't pay that much attention to it because I was doing other things. But you're absolutely right. We need an overall pelvic pain specialty. And Robert Eckenberg outlined that in the book he released a couple months ago, what that would look like, because that specialist has to have expertise in muscles. They have to have expertise in bladder diseases. They got to have expertise in various infections. They have to have expertise in bowel issues, etc. I mean, they have to function with a whole pelvis perspective approach to understanding pelvic pain. Is it doable? It is doable. Getting a major medical organization to sign up on that, that's been, I think Dr. Eckenberg would happily admit, that's been very disappointing. You know, there's kind of this, what did he say in our last conversation? Again, this isn't verbatim from him at all. This is me remembering a conversation like 6 weeks ago. We would all hope that once you get your specialty in urology, that your natural curiosity would have you look beyond that. Like Dr. Weiss, who was legitimately the first American urologist who said, hey, bladder therapies don't work for IC. And he very humbly said, clearly, I need more information. Clearly, my training didn't give me what I needed to care for these patients. And he went and sought that training on his own, and he eventually became a master at pelvic floor muscle issues, which is why his book is so incredibly brilliant. But not every doctor has that quest for knowledge. And the thing is the doctors that go into urology are primarily surgeons. And in many cases, they're some of the best surgeons in any medical school, any graduating class. So doctors go into urology because they like to operate. That's that challenge. That's where they get that high. And so when an IC patient presents to a guy who wants to, or a woman who wants to operate, they're like not enthused. They just want to operate. So finding those young doctors who have a passionate interest in wanting to ease the suffering of pelvic pain patients without wanting to specialize in cancer or erectile dysfunction or whatever, there's a squirrel. It's a very difficult scenario. But I completely agree. Angela said, it's difficult to get anyone to treat pain. You are correct. No, not one doctor talks to the other. My pain is excruciating all the time. No one wants to treat pain. I don't sleep. This is 12 years of this. Angela, I want to talk to you too. I chaired the California Pain Conference. I have testified against congressional panels over the needs for pain care, but at the state level, not at the federal level. So House panels, not congressional panels. And I have worked with not only the DEA and the Bureau of Narcotics Enforcement. Ironically, when I did my conference, the Bureau of the Narcotics Enforcement in California was a chronic pain patient. He was completely sympathetic to what we were trying to do. And it worked beautifully. We had a fantastic event. So call me. I would love to hear a little bit more about your history. I would love to learn more about the pain you're experiencing, because I might be able to open up some new doors for you. Let me give you an example. Angela, I'm going to give you a perfect scenario, true story from the IC Network, from the power of these meetings. So we had a patient a couple of years ago, maybe 4 years ago, I think it was before COVID, who had been bedbound for a year with her IC. And she was young. She was like in her early 30s. She'd been in bed almost for 10 years. Sitting was agonizingly painful for her. And she couldn't work. She just couldn't function. And she came to our meeting, and I started talking about phenotyping. And I went through Chris Payne's phenotyping. So we talked about Hunner's lesions, bladder wall driven, pelvic floor driven. And then I started talking about pudendal neuralgia. So pudendal neuralgia is exemplified by pain when you sit down that gets, hold that thought, Eddie, that gets better when you stand up. Sharp, searing nerve pain. Pain that shoots down the leg, areas of numbness. Anyway, so I'm going through these symptoms. I didn't know her at that time. Here she was just somebody watching this meeting, and that she like, oh, I've never heard of pudendal neuralgia. And she started reading about it. And she went, oh, I have all these symptoms. And so she went to her urologist, obviously as painful that was, and presented the information and said, I attended this lecture online and I'd never heard of pudendal neuralgia before, but I think I have this. And her doctor agreed and said, yes, you do have this. So she's like, wait, you guys said I had interstitial cystitis? I have pudendal neuralgia? And they were like, yeah, you absolutely have the symptoms of pudendal neuralgia. So pudendal neuralgia doesn't have anything to do with the bladder. Again, it's a muscle squeezing a nerve. She had some imaging done. And the imaging showed that she had a massively broken tailbone that had healed out of position. Let me get my model here, and I want to show this to you. Oh, whoops. I got some other things to show you too. So hold on a sec. Okay. So let me we're going to take out this. We're going to take out this. Take out the bones. All right. Hello, pelvis. Hip bone, right? Pubic bone. So this is the front of the pelvis. This is a female pelvis. The male pelvis is narrower and taller. Okay. If we look at it from the back, we've got the vertebrae from your spinal cord. We've got the triangular sacrum. These are vestigial vertebrae that have fused together. The holes that you see here are where nerves go from the spinal cord into the pelvis. And we have the tailbone. Look at that nice, sweet little tailbone right there. Yes, we have a tail. And this tail is the foundational center for our pelvis, because look at everything that attaches to the tailbone and the sacrum. You got muscles that go this way and muscles that go this way. The normal position of your tailbone, if we look at it from the side, is that it hangs down and it curves under. It curves this way. Okay? Just like a dog or a cat walking normally, their tail hangs down and the tip of their tail kind of slides between their legs. In this patient's case, her tailbone had been so badly broken, it was sticking straight out. So no wonder she had pain when sitting. But more importantly, it was at an angle. It was like skewed to one side. So it was like sticking out like that. A gross, major tailbone injury. Now remember, my symptoms started when I broke the tip of my tailbone off completely. My tip was gone. This was when I was young. And I could move it. I could move this little piece of bone around with my finger for years. Now it's just a hard knot of scar tissue. Okay. So anyway, they find that she's got this massively broken tailbone. So for the next year, she works with a physical therapist and she works with a chiropractor. And at the end of that year, they had her tailbone in the correct position. Took a year. And you know what happened? No longer bedbound. 95% of her symptoms are completely gone. She can walk normally. She can sit normally. She can work again. And she even got pregnant. And so here we have a woman who was told for a decade she had an incurable bladder disease. And she had no bladder disease at all. She had a pelvic injury. And we now believe that 85% of IC patients have muscle or bone trauma in the pelvis. And tailbone injuries are so common. Now that we ask about it, it's amazing the number of tailbone injuries out there. And so when we talk, we're going to talk about injury. I want to know about injuries or traumas to your pelvis. For anybody who's in major pain, let's go back over that history, because it's amazing how often, hold on a sec. Doctors don't ask about that. And that's just such an important piece of your story and your history, is that old injury. Or I was working with a patient last week who was a ballerina, and now she teaches ballet. And she's got what appears to be terrible pelvic floor dysfunction. And she had no idea that dance, specifically ballet, is pretty well known for tweaking the pelvic floor. And she also had had a very bad fall. Mary says, the specialist in pelvic pain, or at least get it known so they bring other docs in like a team when it's not clear. Yeah, I mean, our modern day medical system is just so screwed up right now. The biggest barrier really are the health insurance companies, who just want to make money. So they don't want to make the referrals, and they don't want the doctor to spend adequate time with you so that they can do a proper history, so that they can do the proper diagnostic tests, etc. And it's for a complex pain patient, a chronic pain patient, and or a pelvic pain patient where the answer is not immediately obvious. You need more intensive care and you need more intensive treatment, but the health insurance companies don't want to pay for it. So this means a lot of paying out of pocket, right, for some things. Hey, David. Kayleen says, I'm having adhesiolysis on the day I'm supposed to be graduating. Last time I didn't eat or drink enough water to take a Valium. I took an ambulance. I need to have breakfast at the hospital before I leave for the gynecologist. I don't know what to do because this is so important before my bladder Botox and IUD. One day at a time, girl. One day at a time. One glass of water at a time. 1 cup at a time. 1/2 a cup at a time. I mean, you know what you need to do. You know you need to drink, and you know you need to eat. So nobody's expecting you to do a lot, but just try to do more than you did last time, and bring your water bottle with you and just sip on it. How are you feeling today, David? Okay, let's go to Eddie here. Eddie on YouTube. Hi, Jill. I was trying to wean myself off Elmeron, so I stopped taking it. I'm afraid of the eye damage. I'm now in an intense IC flare. Haven't taken Elmeron in 3 days. How prevalent is blindness from Elmeron? The data says that with the limited data that we have right now in the clinical studies, 20 to 30%, roughly, approximately, of patients who are taking or have taken Elmeron develop retinal disease. And then there's a percentage of that. For some, it's mild. For some, it's very, very severe. We just don't have any of that data yet. It's still too soon. You have to, I want you to think about what Elmeron does. Elmeron is a coating. It's a protective coating. It's like a chemical Band-Aid for your bladder. So now that you don't have that Band-Aid for your bladder is going to be a lot more vulnerable to food. So right now, you got to be really perfect with your diet. Okay, you just got to protect that tissue. Most patients who transition off switch over to a chondroitin-based supplement like Bladder Builder or Bladder Rest or Cystomend or Cystoprotect, because the chondroitin has a similar bladder coating effect. And now we have the new Femetry. We can, except that's not a chondroitin supplement. So no, we can't talk that one in there. That's a glucosamine supplement. But anyway, for that, to try to match that bladder coating effect, most patients first try one of those supplements. So have you tried any of those yet? And it takes time. It's not going to, just like with Elmeron, it's like nothing happens overnight. It takes time for it to kind of build up again. I'm surprised that you're having intense symptoms just 3 days later, because what that says then is that the Elmeron that you have been taking isn't sticking well. It's not what we call durable. It's not giving you a long-term effect after stopping the med, and that's pretty disappointing. I would hope that it would have been gradual, and it sounds like that it would gradually, Elmeron coating would gradually disappear. It sounds like that Elmeron coating quickly disappeared after you stopped it. You could also do bladder installations. You could go and ask your doctor if they would do a rescue installation or even an Elmeron installation directly in the bladder. And by the way, we do have another installation that is now being studied. They just finished phase 1B studies over in Europe. It starts with a V, like Vanaltine. I think it's Vanaltine or something like that. And that is a new chondroitin-based bladder installation. So when that comes out, I will let you know if they bring it over here to the US. So Eddie, have you started anything else? And remember too, we have to always think about why would your bladder lose that coating in the first place? And of course, we know that that's estrogen atrophy. So for many patients, are you using any estrogen product to help your skin produce that mucus? That would be very, very important. Hi, Diane. Nice to see you, hon. Hope you're doing well. Beautiful Sunday here in California. Beautiful Sunday. Oh, so let me show you. So. Hold on. Where did it go? It fell off the chair. Okay. It fell down. Where did it go? Oh, that's so weird. So, I am, you know, we're always looking for things that might provide a little bit of relief and or comfort. And one of the big barriers that a lot of patients have is just getting a good night's sleep. And so, um, we're now working with a new company called Life Seasons. Life Seasons Therapeutics. They're the ones that make the Femetry line of supplements, which are really great for estrogen atrophy. I put something from the shelf to my this way. Oh yeah, I did pick it up, didn't I? Where did I put it? I don't know. It's somewhere. Okay, so anyway, Life Seasons make some very interesting sleep products. So one of them is Rest ZZZ, melatonin free. And it has got GABA, magnesium, passion flower, lemon balm. Now that's not citrus lemon, it's not acidic. Lemon balm actually is a mint. Has a bit of a lemony scent that it actually quite good at calming, just kind of calming nerves down. It's got chamomile in it. And the reviews for this were really good. But these were general reviews, not just for IC. And I thought, you know what? That'd be interesting. You know, I know some patients are really struggling to sleep. It's like, okay, this might be interesting to try. And then I also have the Rest ZZ, and they're dissolvable tabs in a small little box that are melatonin based. So we've got two of these. And you know what? Even though this is my demo, not opened, let me do this. It expires next February. Free bottle. The first two people that email me, I will send you this. A Rest ZZ. One of you will get the melatonin free, and one of you will get the melatonin. Let's just throw it out there. It was just kind of a thought. I saw these products and I thought, gee, I wonder if it would help. And then the other thing we have is what they call Relieve RPM, which has some of the same ingredients, but this is to ease occasional aches, relax the body, and promote sleep without habit-forming activities. So this has tetrahydropalmitine to reduce muscle tension, melatonin to support sleep. It's got L-theanine and GABA to help with relaxation. It's got white willow, which helps with occasional mild discomfort. And it's got also it has a little bit of angelica in it. And so, you know, I only got a very small quantity of these, but I thought, you know what, let's just throw it out there. I don't know if they'll be helpful or not. I don't know. But what I do know is that I talk to patients who are completely sleep deprived all the time, and they're desperate. And anytime I can find something that looks promising, I just want to share it because suffering sucks. Diane says, I'm okay. I'm a bit puzzled because I had a urine test for Epstein-Barr by my primary care and it came back negative. I was diagnosed with Hunner's lesions 3 months ago by a neuro urogynecologist, but my urologist I'd been seeing prior the last couple of years said no lesions, just severe inflammation. I keep questioning if I do have lesions and not, especially now that the Epstein-Barr viral infection came back negative. Well, did they take a picture of it? Sure love to see a picture of it. um, Remember, we have two theories, each supported by research showing what can lead to the development of a Hunner's lesion. Theory number one is viral infection like Epstein-Barr, and I've got multiple studies which have now found that. The other theory is that it is neuroinflammation, generally caused by a nerve that is being provoked and pulled out of position, usually by the uterosacral ligament. So there's a bundle of nerves that come out of your bladder, and they're held in place by the uterosacral ligament before they get to the spinal cord. So the uterosacral ligament is essentially a platform that this nerve travels across to get to the spinal cord. When this platform sags, the nerves sag. The nerves get pulled out of position. And that then provokes the nerves and creates neuroinflammation. We call that posterior fornix syndrome, and we've got published at least one published case study, along with many more papers and studies that show that when you restore that ligament, the urinary symptoms and lesions go away. So, kind of concept. So, I mean, that's the other thing is, if you have any history of pelvic floor prolapse, that would then suggest that maybe you have an issue with that ligament. And in the meantime, lactoferrin would be worth trying, because the lactoferrin IC study from last summer showed that red inflamed bladders became pink and healthy, and Hunner's lesions virtually disappeared. So whether it's a real Hunner's lesion or not, clearly your bladder was red and inflamed. So lactoferrin might be a very interesting thing for you to try. Diane says, can you take them if you're on an antidepressant? So the question is can you take GABA? To me, it would probably be the GABA. Let's see. Let's see. So basically what they're saying is, while some studies suggest GABA supplements might not significantly interact with SSRIs, other sources emphasize the importance of consulting a physician to make sure that there are no contraindications or risks. So while some information suggests a low risk, it's crucial to prioritize your safety and consult with a healthcare professional before taking GABA with antidepressant. Diane says, your guy took pictures, but you couldn't see anything because they were cloudy and black and white? What? Ah. Can we say old equipment? All right, Katie. Hello, Katie. I love your name. It's asking about a clinical trial. Let me look at it. Now, I will make this, if anybody wants to go into Zoom, we can go into Zoom. If you want to speak and not just listen to my voice and talk to each other, we can do that. Okay, so hold on a sec. That didn't go anywhere. Here, hold on. Oh no, it did. Okay, hold on. Sweden, eh? The family's home country. I am Swedish and Norwegian. Okay, to investigate the symptomatic effect of the treatment of Kineret for bladder pain syndrome. They want to investigate the molecular mechanisms resulting in bladder pain and investigate the molecular effects of Kineret. So what the hell is Kineret? Hold on. You know what? They're sure not giving a lot of info. Like, what's it supposed to do? I mean, is it an injection? What the hell is it? I mean, they're measuring neuroinflammation at the end. That when it's done, they're going to measure substance P, which is a sign of neuroinflammation. So let's see if we can. Anakinra, used to treat certain. It's an interleukin agonist. Oh, okay, interesting. Very, very interesting. The recombinant form of a naturally occurring protein called interleukin 1 receptor antagonist, IL-1 is a key player in the inflammatory process, works by binding to the IL-1 receptor, thus preventing it from triggering inflammation. Looks like it's an injection. It can increase the risk of serious infections, including pneumonia. It's contraindicated in patients with known sensitivity to E. coli-derived protein. Yeah, it's a subcutaneous injection once daily. And you have to move the injection site around. Huh. Yeah. Ah, okay. So I'm going to put this in the cyclosporin group because obviously it is an immunosuppressive medication. And the risk of immunosuppressants are pretty significant overall. And in this era of COVID, being on something that would suppress your immune system, I would consider that mm, to be only applicable to patients who have really persistent symptoms who have not responded to any other therapies. It doesn't make sense to do for somebody just diagnosed with mild symptoms because the risks would outweigh the benefits. Instead, we've got to do that proper phenotyping, see if we can find underlying causation first, because if that patient is pelvic floor driven, this is pointless. If that patient is estrogen atrophy, this is pointless. If that patient is widespread pain, pointless. But if that patient has Hunner's lesions, it might not be pointless. Angela said, how do we go to Zoom? Is this after the live broadcast? I can start up Zoom anytime and we can go into Zoom. That's fine. I mean, we've been going here now for 2 hours. And I have absolutely no problem going into Zoom if anybody wants to hang out there and have a chat. Eddie said, I also have long COVID. They were putting us on Truvada. My IC started to kick up after taking the Truvada. Very strange. I'm on amitriptyline and I'm still in pain when I go to Euro and they check what? I don't know why Truvada. Let's look that up. Let's see what Truvada's adverse events are. Truvada, while effective for treating and preventing viral infection, can have adverse events, including some related to the urinary symptoms. These can range from mild and temporary, like changes in urine color or frequency, to more serious kidney problems. It's known for causing painful and difficult urination and bloody urine. Yeah, so I'm not surprised your symptoms got worse after this. Are you still taking it? I can see why they have you taking it because of the long COVID viral thing, but the urinary adverse events are pretty significant. Katie said, thanks for your answer, Jill. It totally makes sense. Yeah, it's kind of like with the cyclosporin. Cyclosporin, we actually, some doctors call it a miracle drug in a way, but it's not a miracle drug for everybody. The cyclosporin's place in the ICU world is really for patients with Hunner's lesions that have not responded to therapy, or patients with who are not responding to any of the treatment. They got really aggressive, severe urinary symptoms. They've got a fibrotic bladder. That's when the use of something that's an immunosuppressant and the risks associated with that make a lot more sense. Okay, guys, so I am here as long as you have questions. So the questions are slowing down a little bit. That's fine. I'm happy to take any question you have. Nothing is off the table. But Peggy said, see my chat above. Okay, what did I miss? Okay, here, hold on. Lisa, I would be happy to talk. Okay, hold on. Peggy said, I stopped my Elmeron 4 months ago. I started taking lactoferrin. It has helped so much. Yes, excellent. You're doing the estrogen cream bi-weekly, plus doing pelvic floor therapy. And of course, I watch what I eat. I have a smoothie every day made with vanilla, Greek yogurt, blueberries, banana, 1 cup of almond milk, 1 pack of stevia. I use Greek yogurt daily. It's cured my IBS. And of course, talking with Jill and listening to support every Sunday. It took 2 years, but I'm 80% better. Thank God for Jill, who talked to me when I was in so much pain. Oh, Peggy, you made my day. I'm so happy. See, I can't do yogurt right now. Well, I can do no fat yogurt. My whole routine got messed up when I had my gallbladder removed because I can't do any dairy products right now, pretty much. So I'm a little envious that you can do that. I end up in the bathroom if I do that. Okay, Lisa. So, Lisa, if you want to go into Zoom, we can do that. Diane said, no history of pelvic floor prolapses. My primary care doctor read about the uterus ligament issue, but didn't want to check me. Said I should return to my urogyne to get checked. Yes, I thought the picture should be better. I have a retroverted uterus, but my doctors don't think that should cause the bladder issues. I have been taking lactoferrin for a couple months, and I do think it helps. Thanks. Excellent. Sarah says, yes, I'd love to talk, please. I'm desperate for help. Tomorrow would be best for me. Could you please repeat your email, or better yet, type it in? Yes, I can. I'll give you our phone number too. Just do me a favor. Don't call too early. I mean, right now I'm working sometimes 7 days a week. And normally I would have Mondays off, but I lost Heather, who handled my phones on Mondays, took another job. She got a great offer and took the job. Can't blame her. So if you call tomorrow, and believe me, I will be here tomorrow. Call in the afternoon because I'm just going to chill in the morning. I felt it this morning. It's like this morning when I woke up, it's like I didn't go to the gym. All I wanted to do was go sit outside in the sun. But I came here. And when we're done, I'm going to go paint. I finished my last painting. And I'm going to start a new painting. And by the way, guys, so at the International Pelvic Pain Society meeting last weekend, we were talking about, again, for those chronic pelvic pain patients, and we're talking about the neurological connection and how do we get the brain out of fight or flight for patients who are struggling with very, very high levels of anxiety. And the discussion molded around the concept of safety, that we have to show your brain that you're safe right now. For those of us who have lived with persistent anxiety for years, in many cases that is caused by childhood trauma. I have shared that I was attacked when I was a child by a kid who later became a rapist and murderer, and I did not leave my home without fear for a decade. And again, now that we know to ask these questions for those patients who are showing widespread pain or chronic pain, anxiety is remarkably common. And it can be from physical trauma, it can be from injuries, it can also be from abuse and bullying and things like that. So anyway, so we understand that now. We know that persistent fight or flight amplifies pain. So now we know that we've got to get you out. We got to get ourselves out of persistent fight or flight. And I think that that's one reason why I started to do so much better. Is years ago, I took a fantastic anxiety management class that's given me great skills. So I never let the anxiety get out of control. I know what to do to break the anxiety down. But anyway, in the conversation with all these top pelvic pain experts, the international expert said it's really about safety. Safety. We have to show your brain that there's no reason for it to feel unsafe. You are at this moment perfectly safe. And that's the thing, is that my trauma happened when I was much younger. And yet my brain still remembers being the little redheaded girl running as fast as I could to school and as fast as I could home, because I never knew when I was going to get jumped and attacked. And my identity that is a foundational construct of my identity. It's not my entire identity, but I'm still that little girl who got hurt badly. And so the challenge here is that when you have been a victim of trauma, your brain remembers that. And the way your brain works, this is all controlled by the brainstem. So there's no cognition happening here at all. Your brainstem has one job: to save your life. And the way it does that is it monitors your sensory input. What do you hear? Is it a scream or is it somebody singing? What do you see? Is it a fire or is it a puppy? What are you touching? Is it hot and burning you or is it a soft flower, right? So your brainstem is monitoring your sensory input 24 hours a day, looking for threats. So the way that, and normally when it perceives a threat, like a fire, so let's say you open your front door and you see a fire. Well, obviously, it's 2025. You have a freaking cell phone. You call the fire department. They come out. And yeah, the fire's close, but they take care of it. 2 hours later, there are no flames. Everybody's mopping up. The threat is gone. And it's at that point the fight or flight is supposed to turn off. But it doesn't turn off for us. And so as your brain is monitoring this sensory input, it's going, gosh, has this happened before? Was it good when it happened or bad when it happened? And so this is why, for patients who have a history of trauma, if you smell something that attaches to a memory you associate with that trauma, that brings that trauma right back. Like you've coped with it, you're fine with it. But the memory comes back because it's stoked by some sort of sensory input. So it might be a smell, it might be a taste, it might be something that you see. It comes back. And when it comes back, your brain is going, okay, is this good or is this bad? Is this good or is this bad? Oh, well, this happened when you were really scared and running for your life. So this is kind of bad. And then that's what kind of perpetuates or brings back on a new level of anxiety and a new level of panic. Okay, anyway, long point. So anyway, this conference is talking about giving you a sense of safety, that when we tell your brain you're safe, your fight or flight should turn off. So I have been working really hard to find my happy again. It's been a tough couple of years with death in my family and then with cancer. And the one thing that always makes me smile is BTS, the Korean boy band. I'm 60 freaking 5 years old and I love K-pop. It's just fun. It's just so incredibly fun. And they're all out of the military now. Last week, Sugar got out. We're going to have new BTS concerts. I can't wait. Just makes me happy. Anyway, there's this new show on Netflix. It's called K-pop Demon Hunters. And I smiled through the whole thing. I loved it because it was great music. So you got to find your happy in whatever form it is. Just find your happy. All right, I'm going to start up Zoom. Hold on a sec. Life is just if there's one thing a cancer diagnosis gives you, it's the perception that life is just too short and it's okay to do things that make you feel good. You should be doing things that make you feel good. You should be doing things that give you joy. All right, it's just updating. We'll let it update for a moment. Halfway done, halfway done. While that's doing that, I will tell you we are working on our new IC 101 guide to managing IC flares, much bigger than our magazine, be 3 times as long. Then we'll be doing our guide to managing the IC diet. And then I am done. Then we'll be filming videos on flares, which I should be doing first, but let's see if it'll let me log in. You know, that's always the challenge is, will the software let me log in? It did not. Okay, hold on. Oh, okay, now, oh, look at that. I might actually get into Zoom. I need my code. Karen, I got your email. Give me a little bit. Okay, C. Bevers, the only way I can send you ResEZZ is if you give me a mailing address. Did you put a mailing address in with that email? All right, so hold on. I am starting a new meeting. Yes, we're going to do video and audio. Okay, let's start it. All right, let me get my copy invite link. All right. So for anybody, Sherry says the Osmonds make me happy. Sure. Hey man, whatever works, works. Okay, so you guys on Facebook, you now have that invite. Let me, I have to email it to myself so I can get onto the other computer. So hold on a sec. Okay. All right, hold on. Got to put it over here. You know, I do not know why my hair looks so dry. It's kind of ridiculous since I just... Oh, shit. Okay, so for those of you on YouTube, we're going to go into Zoom for anybody who wants to talk about their case. So let me give you guys the link. All right, now I just want you to know that when you come into Zoom, this is not private. Anybody in Zoom will be able to hear what you have to say. So if you'd prefer to have a private conversation, let's just do it tomorrow. Or I told one person, you're welcome to call me this afternoon. I'd be happy to talk with you because today is a work day for me. Hi, JD. So let me go back to Zoom. Okay, I've got 2 people who come in. Okay, Zola, I'm going to have you mute your microphone. Okay, so we're just going to wait another couple minutes, and then we'll let as many people as we can come into Zoom, and then I'm going to shut down. I'm going to shut down YouTube. Sarah says she won't be able to do Zoom right now, so you may have to catch up tomorrow. You're welcome, honey. Anytime. Ulrike, we are going into Zoom. JD and Ulrike, we're going into Zoom now. So why don't you join us in Zoom? Okay, so we've got one more person who's coming in. There you go. Okay, guys, hold your mic. Okay, that's great. So guys, I hate to shut down anything, but I think we need to go into Zoom now. So I'm going to shut down YouTube. I'll see you guys. If you don't come into Zoom, I'll see you next week. All right? Have a great week. You know who to call if you need a pep talk. I am here.